हेलो डिप्पू।
हाँ गौरव।
अरे this thing Lokesh was asking to start first for me to start first. Only thing
Yeah,
is
start.
I just talked to Varun. Varun is having a bad duty and his phone doesn't have any charge, so he wanted to record the session and he has gone home to get his iPad. So like what do you say?
Okay. That's what. Once people come join in, you start.
Okay. Okay.
Lokesh told you to start first only, no?
Yeah.
Okay. Ask Varun to make someone else host, no? Like me, you, Lokesh, somebody who's gonna stay because if he's having a duty today or something.
Yeah, he will make that. His phone has very minimum charge, some 2-3%. So he told he'll start the session, get his iPad, and then he will do all those things.
So should we wait or what?
He wanted to ensure that the session is being recorded. Only thing is that he told that he will do it. He'll do it within 5-10 minutes. So I think
okay.
by the time everyone joins, it should be okay.
Yeah, because anyways, it's being recorded. He's already put it on record mode.
Okay.
How long will you take?
You can see the screen.
Yeah, now I can
30
see.
to 35 minutes.
Okay. Mainak नहीं आया अभी तक.
12 people have joined.
लोकेश क्या गौतम ने आज पेल दिया इसको. बर्नी बाबा कल से नहीं आने वाला है.
पता नहीं मुझे.
तुझे नहीं पता? नहीं आज तो गौती ने.
तू कहाँ रहते हो बे?
मैं घर पे था आज.
चांद पे रहता हो तू. आज जो हुआ है आज you have to go see the CCTV footage.
Means?
If you want to get the exact effect.
नहीं okay. बर्नी को 2 दिन पहले तो मैंने भी डांटा था उसको. मैं वैसे भी पॉलिसी है डांटने की.
वर्षित वो कुछ नहीं था जो तूने किया है और आज जो हुआ है.
वो भाई डिग्री तो मैं हर लोग की अलग डिग्री.
भाई ये चीज रिकॉर्ड हो रहा है.
या
तो ठीक है ना.
बर्नी को डांटना रिकॉर्डिंग है तो भले जो भी
okay. क्या हुआ बट
मुझे भी जिनेश बोल रहा था कुछ हुआ बट मुझे नहीं पता. मैंने कुछ फिर बात नहीं किया.
ठीक है. 14 people have joined.
तुम लोगों को कैसे पता? डिम्पू और गौरव.
अबे हॉस्टल में पूरा आज दिन भर यही चला है भाई.
क्या हुआ क्या? पर कोई वो शॉर्ट में बताओ मुझे.
गौती is there ना. He will tell. Ask him to give the live version.
गौती है क्या यहाँ पे?
अभी ज्वाइन नहीं किया क्या उसने?
नहीं जिनेश तू बोल रहे. जिनेश साथ में था. क्या हुआ जिनेश?
नहीं है.
हेलो.
हाँ जिनेश बोल.
नहीं
क्या
यार
हुआ?
एग्जैक्ट तो गौती ही बताएगा क्या चिल्ला है. बट बर्नी ने कंप्लेन. बर्नी ने ये बोला है कि पेला है उसको आज गौतम ने. भारत सर को कंप्लेन किया जाकर के उसने.
बर्नी का कंप्लेन किया?
हाँ बर्नी ने गौतम की है जाके. हेलो. एक्चुअली गौतम और बर्नी साथ में सीपीआर में इन्वॉल्व थे तब कुछ हुआ है. मैं एक्चुअली राउंड्स पे था तो एग्जैक्टली मेरे सामने नहीं हुआ. बट फिर जैसे ही बर्नी वहां से निकल के आया उसने सर को बोला कि सर ऐसा ऐसा है. सर ने बोला कि मैं गौतम को बाद में कुछ लाइक ही विल डिस्कस विद गौतम. बट कुछ बोला नहीं सर ने. सिर्फ मुझे ही बोला कि यार either you talk to your seniors and get relieved or all of you have to come and all of you have to be there करके.
किसने बोला ये?
भरत सर ने.
सबको नए स्टेटमेंट्स आते रहते हैं. चिंता नहीं करें.
हाँ वही.
Okay, Varun I spoke to. He said he will not be able to join immediately. Go ahead, Gaurav. 15 people, 15 लोग आ गए.
Yeah. We'll start then. Voice is audible. Okay. ठीक है. So we'll discuss post CABG interventions. So I thought we'll start with what are the essential medications which we should give post CABG. So obviously statins we all know, and the evidence is post CABG trial. It was found in this trial that statins are associated with improved graft patency rates and reduced MACEs. Then obviously aspirin we all know, no need to discuss. Then the role of DAPT, I have enlisted some 2 trials and some meta-analysis. But in general, what you have to remember is post CABG, in patients who had stable CAD, ACCHA gives a 2B recommendation for DAPT in the form of aspirin plus clopidogrel. And this thing, ESC does not make any recommendation. If there was any other indication for the DAPT, then accordingly that will be used. Otherwise, post CABG stable CAD, there is no specific mention of DAPT in ESC guidelines. And for ACS post CABG, this thing, it will be class 1 recommendation for 1 year of DAPT, and subsequently 2B recommendation for extended duration. So the evidence was Cascade and Ruby trial. They were negative for clopidogrel. And then there was a meta-analysis. You can go through the details. I won't discuss because it is not something which we should waste our time. Only thing is that this meta-analysis had showed that within the first year after CABG, if you give DAPT, even after stable CAD, it is associated with better SVG graft patency rates at 1 year. So thereby ACCHA 2B recommendation currently. Then after that, some many times we miss the hypertension. So there should be strict hypertension control in the form of ACE inhibitors, beta blockers, and if required, CCB and diuretics. Smoking cessation is essential, glycemic control, weight loss, and very important, one thing which we miss, influenza vaccination. It has been found that annual influenza vaccination is associated with reduced CV events post CABG. So coming to how does the coronary artery disease progress in the grafts and what happens in the native vessels. So as we all know that in the native vessel CAD is a very slow process. It develops over 10 to 20 years, and there is a component of inflammation along with lipid accumulation. So a characteristic atherosclerotic native vessel CAD plaque, it is eccentric. We all know that it is eccentric, and it has a good fibrous cap. And there is partly inflammation and partly lipid accumulation. Whereas if we see the grafts, particularly the saphenous venous grafts, what we'll find is that there is a circumferential plaque accumulation. And this circumferential plaque accumulation is the plaque burden is very heavy, and it is over a very long segment of the graft. And another thing is that they have a very thin fibrous cap, or sometimes they don't even have a fibrous cap. So they are very friable lesions, the saphenous venous grafts lesions. So as in my previous discussion on CABG, I had told that once you have grafted a native vessel, after that the native vessel CAD progresses very rapidly after the grafting. And this and all we have discussed already in the previous talks. Just for the sake of completion, I have put the occlusion rates. But the important thing is that in hospital, up to 10% of SVGs can get occluded within the same admission for CABG. And so in hospital SVG failure, or I have kept this together within the first month after CABG, what are the common causes of SVG failure? So first, as we can understand, it is acutely after CABG. So there will be some surgery related issues. So poor graft mobilization and harvesting, conduit defects. Sometimes they will put the upside down. The grafts will be put upside down. Anastomotic errors, poor native vessel runoff. So if the distal runoff in the native vessel is not good, then the graft failure chances are very likely. Then the competitive flow is there from the native vessel. And then possibility of thrombosis. So this acute thrombosis in the early phase occurs because of 2 reasons. One is because of the poor handling by the surgeon. And another thing is that the venous graft was never exposed to systemic pressures, arterial pressures. Now it is getting exposed to systemic arterial pressures. So it responds by endothelial damage. There is endothelial damage and it responds by thrombosis. So thrombosis can occur early after CABG. And then last lesser known mechanism in the early phase is proximal or distal anastomotic site stenosis, but this is less common. So you have a patient has undergone CABG and you have been called in the recovery. in the view of suspicion of graft failure. So how do you suspect that? So the patients may or may not have ischemic symptoms, but definitely he will have ECG changes. There will be biomarker elevation. So as we all know, according to the 4th universal definition of MI type this thing. So where they have mentioned post CABG, the upper limit should the biomarker elevation should be 10 times of upper limit of normal. But in our previous discussion, we had realized that it is actually 70 times. It has been updated. Thomas sir had put the pic also. So this one is just for the sake that it is.
No, Gaurav, that was with
That is a
respect to
different
fourth definition. It is 10 times the upper limit only.
Yeah, I know. That is what when
PM has given 70 times bar 35.
No, that is a different definition. Different body has given different definition.
Correct.
Universal
As per-
MI is 10 times.
But the thing is, the Noble Excel trial, if you also see,
That is okay. That is different. But
that
the
is why I have
guideline is this.
mentioned the 4th universal definition criteria only here. Okay. So, but if someone asks, you should remember that other bodies have given 70 times of upper limit of normal as the cutoff. Okay. So then new RWMs and then hemodynamic or electrical instability. So these things, when present in combination, then you should suspect that there is acute graft failure. And any patient at any stage, even in the subsequent section when I discuss, when you are suspecting a graft failure, the role of medical therapy is very minimal. They say that if the culprit vessel is the acutely occluded SVG graft, then the role of thrombolysis is very minimal. This I am not saying for this acute subset, even for the subsequent subsets also, this holds true. And obviously, in this acute subset, you should not thrombolize. Suture dehiscence, perforation, bleeding will be very high. But even apart from that, the efficacy of thrombolysis for occluded SVG graft is very poor. So thereby they say that in cases of at any time after CABG, if you are suspecting graft failure, you should go for early CAG and document whether what is the cause of the presentation. So if you find an occluded SVG graft in the acute phase, first thing is you do not thrombolize. The second thing is you do not attempt the PCI of the occluded SVG graft or the anastomotic site, because it can be associated with perforation or embolization, distal embolization. And the treatment recommended is, if amenable, you should do the native vessel PCI. If the native vessel PCI is not possible, then you leave the patient on conservative management, let the myocardium get infarcted. But if the myocardium is more than 10%, the ischemic myocardium is more than 10%, then you should consider redo CABG. So the most important point where you consider redo CABG in such cases is when there is a large area of jeopardized myocardium, that is more than 10%. When there are clear-cut anastomotic errors, okay, so obviously it is because of the anastomosis the graft is failing. So once you reverse it, it will get corrected. So in these cases, you should go think of redo CABG when several important grafts are occluded. So if a patient has undergone a triple vessel CABG and only the RCA to SVG to RCA is occluded, then if at all the ischemic myocardium is less than 10%, then you can better skip it. You let the patient have the infarcted myocardium rather than going for a redo CABG, because the procedural morbidity and mortality will be very high. So only when several important grafts are occluded, then only you should consider redo CABG. When there is a non-patent arterial graft to LAD, so you have done an emergency CAG and you have found that the arterial graft, the IMA to LAD has been occluded. In those cases, you should consider redo CABG. And when the anatomy is not amenable to PCI and there is a large area of ischemic myocardium, then you should consider the redo CABG in cases of acutely occluded grafts, SVG grafts. So what about the acutely occluded IMA graft? The incidence is much less, about 2%, and the causes are more or less similar as to the SVG failure, because we can understand it is because of the surgeon error. Okay, so apart from that, one more cause which they say is because it's a artery, so it has a lot of smooth muscle. So because of the inflammation associated with the pericardiotomy syndrome, it can go into spasm, and that can be the cause of failure of the IMA. And thrombosis and stenosis in the acute phase or even in the subsequent phases for IMA grafts is, thrombosis is very uncommon for IMA grafts. Stenosis can happen in the subsequent phases, but in the acute phase, thrombosis and stenosis are usually uncommon. So the management guidelines will be the same as for SVG. You don't thrombolize. And then here, if the native vessel PCI is not possible, here you can try PCI of the occluded IMA. Okay, but always the better option will be to prefer the native vessel PCI. And reduced CABG can be considered because here we have a occluded IMA graph. So reduced CABG will be a strong consideration here. So moving on, I thought that we will discuss how the SVG disease progresses after CABG. So within the first month, as I have already mentioned in the last page, how does the disease progress? So within 1 to 12 months after CABG, the predominant mechanism of disease progression is intimal hyperplasia or thickening. So as I said, there is diffuse circumferential thickening, which accounts for less than 50% of luminal area. It usually never crosses more than 50%. Only in less than 1% cases, it extends to more than 50% of luminal area. And the most common location of this intimal hyperplasia is the perianastomotic areas, either the proximal or the distal anastomosis. And it occurs predominantly because of the exposure to systemic pressures and the poor graft handling during the surgery. So it is basically a response to the excessive arterial pressures and the surgeon's errors. And then it is the amount of thrombus in this early phase, in the first year after CABG in the SVG is relatively lesser. And as we go ahead in time, we'll understand that the amount of thrombus burden in the SVG grafts is much higher. So in this phase, there is less of thrombus and there is less chances of distal embolization and no reflow. So we can understand here that the need for embolic protection devices and the chances of no reflow will be less if we are addressing SVG graft within 1 to 12 months after surgery. So the standard treatment which they recommend is balloon angioplasty plus minus if required stenting, because they say that it is at the site of anastomotic errors, particularly the distal site. Even balloon angioplasty most of the time suffices. And the SKY guidelines say that it is a two-way recommendation for SVG intervention in the form of POBA plus minus stenting within the first year after surgery. And important thing that we need to remember is that it has high chances of restenosis up to the extent of 50%. So moving on, 1 to 3 years after CABG, this lesion, this intimal hyperplasia, it starts accumulating foam cells and then it forms the fatty streaks. And now this fatty streaks, they can present in the form of new stenosis in the SVG, and at the same time, the disease in the native vessel is also progressing rapidly. So within 1 to 3 years after CABG, the patient can present because of the disease of either of the native vessel or of the SVG. So we will know the definite answer after CAG only. Okay. And whatever it is, if the revascularization is indicated, it will be always preferable to go for the native vessel PCI over the SVG PCI. But still, if the anatomy of the native vessel is not feasible for PCI complex anatomy, which we'll come to subsequently, SVG PCI can be done as a two-way recommendation. This is SKY. This is by SKY. ESC and ACCHA. ESC does not make a separate recommendation for this category. So 3 to 5 years after CABG, this lesion now progresses and it starts forming a necrotic core. And this necrotic core is having high chances that anytime it can go into the unstable phase. There can be intraplaque hemorrhage leading to necrotic core expansion, and they present as ACS. So in this subsets, now we can understand there is necrotic core, there is intraplaque hemorrhage, there will be a lot of thrombus. So here, there should not be any doubt in the native, in always considering the native vessel PCI, and this should always be, and if you are considering a SVG PCI during this phase, you should always consider it along with the EPD. There should not be any doubt there. So these lesions are thrombus rich and they have thin friable fibrous caps. So more than 3 years after CABG, SVG grafts have heavy plaque burden and thrombus, and thereby native vessel PCI is always preferred. Important thing that we need to understand is that thrombus is a term we always use in terms of ACS. But this SVG grafts, they are particular in the regards that even if they present with stable IHD, like stable angina pectoris, the lesions, they have lot of thrombus. So even for the stable IHD subset post CABG, SVG interventions, you should be aware that there's a lot of thrombus and you should always consider EPDs. So now within 3 years after CABG, just summarizing what we discussed, thrombotic content is low, thereby SVG balloon angioplasty plus minus PCI can be considered with or without EPD. But even here also preference will always be given to the native vessel PCI, because the outcomes after SVG PCI are not as good as that after native vessel PCI. So how do you define early graft failure? Early graft failure is defined as within 6 months of CABG, and late graft failure within more than 6 months. हाँ,
अरे हाँ, अरे मान लो पेशेंट को like after 3 years SVG, after 3 years CABG, एनस्टेमी करके प्रेजेंट हुआ है, ठीक है, और SVG to RCA टोटल ऑक्लूजन है, ठीक है, और RCA जो नेटिव वेसल है that is not amenable, ठीक है. नाउ मतलब मेरे का जो क्वेश्चन है ये वो है कि क्या टोटल ऑक्लूजन SVG post 3-4 years should we attempt to open it, or like in actually there is some consensus for total occlusion.
CTO-PCI.
Exactly, CTO-PCI. But then again, you will consider the SVG CTO-PCI or native vessel CTO-PCI. In this regard, you have to consider only when with the background that patient is symptomatic. It is an NSTEMI. If at all, it is a low risk NSTEMI. If the patient is now asymptomatic, the ischemic myocardium is very less, then you can leave the patient on conservative management also. You have to see the whole picture. Now, if at all it is indicated to go ahead with the revascularization, then you will, based on CT data, you will decide whether which is more complex. The native vessel CTO PCI is more complex or SVG PCI. If the native vessel CTO PCI is less complex, then you will go for a native vessel CTO PCI. Otherwise, you might consider doing a SVG CTO PCI. I will come to that later.
Okay.
So, early graft failure, this is within 6 months of CABG, and during this phase, as I told, this is predominantly because of intimal hyperplasia. So the patients can present either with a stable angina or they can present with ACS, and usually these are due to surgical errors. And late graft failures, they have more chances of thrombotic events, so they more commonly present with ACS. And here the intimal hyperplasia will now start progressing to the further stages. So at any time after CABG, if you are suspecting graft failure, do early CAG, and thrombolysis is usually ineffective. The same things which I mentioned. Always for a post-CABG intervention, even for a CAG, prefer femoral access. You can also consider left radial access, but the radial CABG trial had shown that even for a CABG CAG post-CABG, the radiation dose, the contrast exposure amount is much more with a radial access as compared to the femoral access. So better will always be femoral. So intermediate SVG lesions. What do you mean by intermediate SVG lesions? One thing is that they define intermediate SVG lesions here as 30 to 60% luminal stenosis. Okay. One thing that we need to understand is the cascade of events which I showed is you can understand that within 5 to 10 years after SVG grafting, the patients are progressing much more rapidly, and the disease is progressing much more rapidly as compared to the native compared to a patient who has not undergone CABG. The rate of progression in disease of graft is much faster. Okay, so you cannot predict if there is an intermediate lesion on angiography, and you would say that okay, we can defer the procedure. You may not be very sure that this patient might not come back with ACS in the near future, because you cannot predict the rate of progression of SVG disease. It can sometimes present within 1 month also later on for intermediate lesions. So these trials were done, Velity 1 and Velity 2, for determining the role of stenting or balloon angioplasty in patients with intermediate SVG lesions. So there was a trial, Velity 1, which was a small trial, which found that the intermediate stenosis, when addressed with PCI, the outcomes are reduced, the misses are reduced. But the large trial, Velity 2, showed that there are no outcome differences. So currently it is recommended that you need not intervene for the intermediate SVG lesions. And at the same time, what is the role of FFR? Lokesh had nicely covered in his talk. So I am not focusing on this, but we can understand that the same area of the myocardium can be supplied with by the graft, by the collaterals, or by the native vessel. So the actual contribution and the significance of that FFR value of the SVG lesion will be very much fallacious. So that is why FFR is not considered in these subsets. Unless you have both, there are no collaterals and the native vessel is occluded and the supply is purely via the graft, then you might consider the FFR values significant, but otherwise it's fallacious. So moving on, what are the basic issues with SVG PCI? As I told, there is a lot of thrombus, so chances of distal embolization and thereby no reflow. And there has been abundant evidence that shows that no reflow is associated with higher MACEs in these subsets. And the second thing is, even after doing the PCI, there is high chances of restenosis post PCI and rapid SVG disease progression. So for the second thing, we can't do much. Only thing that we can do is ensure that the patient has a very good prescription and he is very compliant. For the first part, what we can do is we can use embolic protection devices, and there is a lot of evidence for the use of EPDs in SVG PCI. ACCHA gives a class 1 recommendation with level of evidence B, and ESC 2A recommendation with level of evidence B. Actually, ESC previous guidelines, it was class 1 only, but somehow they have downgraded it to 2A. The first trial of embolic protection devices which was done was the Sjicsr trial, where they had used the guard wire system. So this guard wire system is basically like a balloon. It is a balloon and which is having a separate wire of its own. And this balloon goes and occludes the distal vessel, and thereby all the thrombotic embolized material get accumulated above the balloon, and later on you can aspirate it and remove the balloon. So this Sjicsr trial showed that there is significant difference in MACEs when we use the EPDs without no EPDs. And this is the only trial where they have compared EPD versus no EPD. All the other subsequent trials are comparing EPD versus another EPD. But the outcomes with this Sjicsr trial were so clear, and it was such a landmark achievement that it was well understood that EPDs are definitely needed for SVG PCIs. But subsequently in 2017, this guard wire system which was used in Sjicsr trial was banned, because we can understand we are occluding the distal vessel for a long time throughout the whole intervention, and thereby the distal perfusion is compromised. There are many other disadvantages, but there is no point discussing that for this thing. Then moving on, the currently available EPDs which are there are either the field wire system or the spider wire system, and these are the two recommended right now. So filter wire was evaluated in the FIRE trial, where it was head-to-head against this guard wire, and it was found that it was equally efficacious. And the spider is the spider system. It was also found to be equally efficacious. There are other subsets, other types of EPDs, but these three trials are the one which we are supposed to remember. And another thing is this proximal EPD was also tried, because the prerequisite is, even for a carotid PCI, when Mainak had discussed, he had told that if this is the vessel, this is the lesion, and we need to have a distal landing zone for the distal EPD, which is at least 3 centimeters. So if we don't have this distal landing zone, we can't use the EPD. So thereby the role of proximal EPDs came to, and this was evaluated in this proximal trial, and it was found that it is as good as a guard wire system. But the problem is, then again, this proximal EPDs also were subsequently banned because of the same thing, the perfusion related errors, and this thing, there was vessel trauma with this proximal devices. So thereby it was subsequently banned. And current recommendation is that these two are available and these two are recommended. So this is the filter wire system, where it has a wire of its own, and there is a mesh-like basket where obviously all the embolic material will collect, and after the intervention you can aspirate, and then again if needed you can reinsert it, and then you can go ahead with your procedure. So distal EPDs require a 3 centimeter of landing zone, and thereby we can't use it for distal anastomotic site lesions. We can't use it because there is no distal landing zone. One thing is that they say that some people have tried landing it, the distal EPD in the native vessel, but that is also very controversial. So for our purpose, we can understand that anastomotic site PCIs, distal EPDs is difficult. We can't use them. And EPDs, as I told, aren't required for instant restenosis. So EPDs can be skipped for early SVG failure, where the predominant mechanism is intimal hyperplasia. And what about the another consideration, that if a patient has undergone SVG PCI and in his follow-up, he comes back with ISR. So we know that this ISR predominant mechanism is neointimal hyperplasia and thrombus is less there. So in these subsets also, we can skip the EPDs. So moving on, apart from EPDs, what are the other modalities that can be used to prevent the distal embolization and no reflow? So laser therapy has been found to be very effective, where they have found that it vaporizes the plaque and the thrombus, and there is less chances of no reflow. And recurrent ISR, if there is recurrent ISR post SVG PCI, brachytherapy can be used. But then if there is recurrent ISR, then redo CABG should also be a consideration. So this is a figure which shows that when during an SVG interventions, how to prevent a no reflow. So the most important thing is EPDs. Then if the no reflow happens, as Varshit has told in his talk, the drug therapy for no reflow. Then important thing is that SVG interventions, you avoid post dilatation, and you use always a undersized or a same size balloon. You never cross the vessel diameter in the balloon size. Okay, so you always be less aggressive for a SVG intervention. And some people have also used undersized stents, but problem with undersized stents is the chances of thrombosis is high. So that is why apart from these three, the level of evidence for these other things is not much. So thereby these three things at least we should write in the answer. Then what about GP2V3A inhibitors? As we can understand, there is a lot of thrombus, so GP2V3A inhibitors should have a role, but actually they do not. And whatever trials, EPIC, EPISTENT, EPILOG, PURSUIT, IMPACT, no need to remember so many names, just remember EPI. So these three you can easily recall. So what they found was that despite the thrombus is very high, with or without the use of GP2V3A, the outcomes were not different, and this GP2V3A unnecessarily was increasing the bleeding risk and chances of perforation of the SVG grafts. So thereby they in 2011 SKY recommendation to class 3, it is not recommended. So what about the stent selection in SVG PCI? First we'll see BMS versus POBA. So there were two trials, SAVE trial and saphenous vein de novo trial, where they found that obviously we can understand it's simple, that BMS versus POBA, the elastic recoil will be less, and the greater the lumen achieve will be greater with BMS, and restenosis will be lesser with BMS. But in this SAVE trial, the restenosis was not significantly different between the two arms, but in this saphenous de novo trial, it was different. Overall, we can understand that the BMS will be associated with lesser MACE, lesser elastic recoil, and greater lumen area with BMS. Thereby, BMS is to be preferred over POBA. But what about BMS versus DES? So there's a lot of controversy here, and there have been many studies. But the current recommendation is that you can prefer anyone. And they mentioned that if the patient can't afford a DES, then you should go for BMS, because the outcomes in multiple studies have been found to be the same. Important thing is that many of these trials had many of limitations. Most of the trials had first generation DES, only one trial had second generation DES. That too had many limitations. I'll discuss them. But the understanding is, because we know that drug-eluting stents are obviously better, so we should in general use drug-eluting stents only unless the patient is not able to afford, then we can consider using a BMS. So a large meta-analysis showed that there is no difference between DES versus BMS, and these are the main 6 trials which have happened in DES versus BMS. So all these trials use first generation DES except this DIVA trial, in which almost 90% patients had a second generation drug-eluting stent. So the important ones I have marked. The first trial was risk, where they found that at 6 months, it favored the drug-eluting stents, and the events was much lesser with the drug-eluting stents. The arrowhead is towards the preference, the better one. So but at 32 months on the long-term follow-up, we found that the events were lesser with BMS. And in fact, this trial showed that the mortality was higher with DES use rather than BMS use. So the lot of controversy there. Then SOS showed that DES is better any day as compared to BMS at short and long term both. Then came the large scale landmark trial, Sjicsr CABG, which at 1 year of follow-up showed that DES is better, but at 5 years of follow-up, it found that they are equally good. There is no benefit. Then this DIVA trial, which used the second generation stents, this trial also found that there are similar outcomes. Now this DIVA trial, the thing is that all these trials, except the DIVA trial, they were non-blinded, because the choice of DES versus BMS was done after doing angiography. So the operators were not blinded. So there was a lot of bias. And then this DIVA was the only trial which was blinded. But at the same time in this DIVA, the bare metal stents which were used were thinner struts, okay, compared to the older trials where the thicker struts was there. So that would have accounted for lesser events with the BMS. Then the fact that the pathophysiology of SVG grafts is very much different as compared to a native vessel CAD, where the evidence of DES preference over BMS is much higher. So the pathophysiology related facts, they say that because their progression is different and the plaque composition is totally different, the efficacy of the drug in the vessel milieu may or may not be achieved with the drug-eluting stents. And there are many other points in this DIVA trial. But for us to understand, it is that DIVA in general found that there was no difference, and this basket was another trial which favored DES. But the combined meta-analysis of all these trials found that there is no difference. And the basic explanation for this is that BMS, we understand that there is early neointimal proliferation which starts at 6 months. But the DES, the problem with DES is the late stent thrombosis, as Darshan had told in his talk, and late lumen loss, which starts at 2 to 4 years. So there is a late catch-up. So obviously, when you see the early 6 months, 12 months outcomes, they will prefer DES. But when you see the long-term outcomes, you will find that there was no difference. Thereby, currently, there is no preference over one another. But I think we should understand that we should use DES until the patient is not financially capable. Moving on to the SVG CTOs, the opening of SVG CTOs is not recommended. It is class 3 recommendation, okay, because the procedural risk is very high, the outcomes are very poor, so it is not recommended. But then again, important thing is that if, as Varshit was asking, if there is native vessel CTO and SVG CTO as well, so the native vessel CTO can be attempted to open by opening this SVG CTO, going retrograde and crossing the wire, and then achieving this PCI of the native vessel. What they say that, okay, I'll discuss this in the next slide. Wait. So one thing I just wanted you to focus on that, so these are the different types of, I have not put this picture in the notes because I didn't think that it is something that is very important for us to remember. So there can be 3 types of stump of the SVG grafts. One is the flush, one where you can find the nipple. So obviously where you have the nipple, you know where you have to orient the wire. But in such cases where there is flush occlusion, you don't know where to where to go ahead with the wire. Thereby the chances of perforation is very high. So in these subsets, nothing is to be done. It is not to be touched. In these 2 subsets, you can try opening them for the retrograde crossing. And then this is showing the distal anastomosis. So this is the graft, this is the native vessel. So obviously when I am crossing the wire, I can easily go like this. I can easily go like this. But for me to go like this, it is not possible. So these are the anatomies where you should also focus. You have to see the whole picture along with the clinical picture, whether the procedural related risks are better than the benefits. So Varshit, hello? Varshit? So you got the point, right? So it is very difficult to say and you have to decide on a case-to-case basis depending upon the clinical scenario and the angiographic picture. Okay, so this is algorithm where they say that if there is a SVG lesion, so first thing you should consider whether the candidate is suitable for redo CABG or not. So as I had discussed, if there is no patent arterial graft to LAD, then you should always prefer CABG. So you look for a patent arterial graft to LAD. If that is present, there are no anastomotic errors or lesions. It is a single graft occlusion, and if the anatomy is amenable to PCI. So obviously all these factors say that you should not consider CABG because there is no need. And the mortality with redo CABG will be higher, although the recent STS data shows otherwise. But all the other data, they show that redo CABG is associated with higher morbidity and mortality. So obviously in these cases, you should consider the native coronary vessel PCI. Now you see the lesion complexity of the native vessel PCI. Is it a CTO? Is it heavily calcified? Is it tortuous? And these two things you can see on the CT, anastomotic site stenosis, and whether there is a stump or not. So based on these findings, you will decide the complexity of the lesion of the native vessel. If it is not complex and it is amenable to PCI, you straightforward move on to the native vessel PCI. There should not be any doubt. If it is not so, and some of these factors are present which make you think that it is a complicated procedure, then you should consider the SVG lesion and you should consider its complexity. So now you should see which is more complex. Okay, so if the native vessel PCI is lesser complex, then again you should go for the native lesion PCI. If you feel that after comparing both of the lesions, if you feel that the SVG PCI is less complex, then you should go with the SVG PCI. And even some authors say that if the native lesion PCI was not possible and you have opened the SVG graft by a PCI, and then what you do subsequently after a few months, you reattempt the native vessel PCI. Okay, and once you have achieved successful recanalization of the native vessel, you do coil closure of this SVG graft. Okay, so problem here is that it is very controversial. These things have not been evaluated in trials. So I have not put those things in the notes because it is very controversial. And I don't think we will be able to comprehend it. So that is why we'll keep it simple and end it here. And if at all these criteria are not met, patient is a candidate for redo CABG. And if the Lima to LAD graft can be done and feasible, then you should consider redo CABG. That should be the basic understanding. And this is the from the ESC revascularization guidelines. So this thing I have already discussed. It is a class 1 recommendation how to suspect and when to suspect. And emergency reoperation or PCI should be considered class 1. So only when patient has severe symptoms or large area of ischemia, that is more than 10%, class 1 for revascularization, either in the form of PCI or CABG. Consider PCI over redo CABG as a 2A recommendation. Obviously, if there is no patent arterial graft to LAD, then redo CABG should be considered. And IMA should be the conduit of choice if it was not used previously. And distal EPDs are 2A recommendation in ESC, whereas ACCHA it is class 1. And obviously, native artery PCI is always preferred over bypass graft PCI. Another important thing is that this SVG interventions, almost 50% of the cases when you are doing an SVG intervention, patient will have CKMB elevation. And if there is a major CKMB elevation more than 5 times of upper limit of normal, then it is associated with increased mortality. Even minor CKMB elevations have been found to be associated with late mortality. So you can understand the SVG PCIs are heavily highly complicated procedures associated with poor outcomes and increased mortality. Thereby, you should always prefer the native vessel. Try not to touch the SVG.
ये गौरव कहाँ पे 2A रिकमेंडेशन है एम्बोलिक प्रोटेक्शन डिवाइस का?
ESC में, ESC
पक्का है ना? क्योंकि कहीं पे अब मुझे अभी वो रेफरेंस नहीं पता है गाइडलाइंस का, पर जब भी ये मैं पढ़ा था या डिस्कस हुआ था तब एम्बोलिक प्रोटेक्शन डिवाइस हैज नो रोल नाउअडेज.
No, Varshit, that is for no reflow thing which you had discussed. In general, for native vessel PCIs and all, it is not recommended. But for SVG and carotid PCIs, they are clear-cut recommendations. Okay.
This is correct only, Varshit. It is in the 2018 revised clarification guideline. In fact, according to AHA, it is still class 1.
Class 1.
Okay, fine.
So moving on, DAPT after SVG PCI. See, there is no recommendation made, but we can understand the patient has undergone a PCI, so we should give the DAPT, and it should be a prolonged duration, because there was a trial where they found that when giving clopidogrel and aspirin for more than 2 years after SVG PCI, the 5-year outcomes were much lesser. So they say that you should consider prolonged duration DAPT after SVG PCI, more than 6 months for stable CAD and more than 1 year after ACS. And whatever the trials have been is basically in the form of clopidogrel. But prasugrel, ticagrelor, there are many studies like Plateau, Triton, TIMI. There were some subsets where these things were seen. But because there is no large-scale data on these, there is no recommendation. But whatever their studies were, they found that there is better outcomes. So according to the clinical profile of the patient, I think we can consider prasugrel or ticagrelor depending upon the bleeding risk and everything. So coming to the last portion, PCI of the IMA graphs. So most important thing is, and we don't do this, at least I have not seen anyone doing this in our cath lab, before hooking the IMA and taking a CH check shoot of the IMA, we never look for the subclavian osteoproximal stenosis. They say that up to 7% of these cases, they have actually subclavian osteal stenosis, and that is causing a coronary steal. The blood is getting recircuited from the coronaries via the lima to the subclavian, and that is why the patient is having angina. And I don't know what is you people experience, but I have never seen anyone of our consultants do this. Okay, so this is one thing we should keep in mind. And another thing is why this IMA endothelium is having a very good patency rates up to 80-85% after 10 years. So this is because the IMA endothelium has fewer fenestrations, the intercellular junction permeability is less, it has antithrombotic properties, the endothelium, and there is high level of enos. So these account for a better patency for the IMA endothelium. As we discussed, occluded IMA to LED, prefer reduced CABG. Common sites of IMA disease, most common is the distal anastomosis, and they recommend that for this distal anastomotic IMA disease, only balloon dilation is sufficient. And that is the current understanding, that only balloon dilatation should be done. For proximal and body of the IMA disease, you can consider stenting. PCI of the IMA grafts is associated with much better outcomes compared to SVG PCI. So definitely they say that as compared to SVG PCI, we always say that native vessel PCI should be preferred. For IMA grafts also the same, but then again IMA graft PCI can also be considered equal. And one thing is that if the lima is very tortuous and you have passed a wire or balloon and made that tortuous segment straightened out, then it leads to the appearance of pseudo lesions, which is basically nothing but the accordion effect. And this pseudo lesions can lead to flow compromise and ischemia. So what happens is something like this. This was the vessel and you have passed the wire straightened, and this causes flow compromise. So this is reversible. Once you withdraw the wire, it reverses. So this is a very important differential for procedure related vasospasm, which obviously will relieve with vasodilators and dissection. So as I told, these pseudo lesions are reversible with wire withdrawal, whereas dissections are not. And this is a picture which is summarizing the whole discussion. Very good article, 2 articles Dimpu had given me. Almost everything is from those 2 articles only. And any post CABG PCI when we are doing, there are 2 important complications that we need to remember. One is the lot of contrast which we'll be using. So chances of CIN and going for hemodialysis is very high. And another thing is there can be procedure related perforations up to 7% of the cases. Previously, they used to think that it is benign. Even if perforation happens because of post CABG, post surgical subset, there will be adhesions and accumulation will be less. we need not bother. But what happens is it becomes a loculated effusion, which is called as a dry tamponade, and this may require drainage sometimes. Ashte appa, mugito.
Gaurav, regarding this thrombolysis, if the post CABG patient presents with the STEMI in the same vascular territory, like for example SVG, he has undergone previously SVG to RCA, and he presents with inferior wall MI, that too after 3 years. Like, what is like specific guidelines are there for thrombolysis? Is there, like you told early CABG thrombolysis contraindicated? Like after
No, I didn't
all
say
the-
it is contraindicated. See, Venki, the thing is that they say that you can't predict which it is because of the native vessel or the SVG which has occluded based on clinical and ECG evidence. Okay, so if it is a native vessel occlusion, thrombolysis might help. But if it was a SVG occlusion, thrombolysis will not be very helpful. So that is why they say that in this subsets, it is better you go take them to the cath lab, do a CAG, and then see whether it is a native vessel or a SVG which is occluded. And if it is amenable to PCI, then obviously it is like doing a primary PCI. Na? You will not obviously subject that patient to thrombolysis, even if it is a native vessel disease. Okay, it is not said anywhere that it is contraindicated, but it is our understanding that because the outcomes of occluded SVG with thrombolysis are not good, thereby we should not consider doing that. Rather, we should take them to the cath lab. Hello?
okay, Gaurav, yeah.
Ha, Gaurav.
Yeah, any other things or shall I stop?
Yeah, no, nothing. Basically, you stop sharing. Let Mautika start sharing. I'll just tell 2-3 important points that basically in the angiogram, when they keep searching for graft. Hello, am I audible?
Your voice is breaking, Limpu. Yeah, now it is okay. Yeah, tell.
Hello, am I audible?
Yeah, tell.
Yeah. So basically, when we do an angiogram for left-sided grafts, no, there is one order in which actually they usually most of the places follow this order. The one which is most below, just above the left coronary ostium, will be always an LAD graft if they have put an SVG to LAD, and if they have not used a lima to LAD, that is. Then above that will be diagonal, and above that will be OM. So it basically goes from LAD to diagonal to OM in the order from below to above. That's something to be aware of when we do a graft angiogram. Okay, like
I
how
will
when we
make this diagram and put it. It is an important thing, I think, which we should know.
Yeah, and basically, I think all of us know that when we are trying to hook a lima, we use a JR or a IM or a IM this thing catheter. And that picture which you have actually showed had that 1:1 balloon dilatation. So that is basically in PCI something called as a cheese grater effect. So what is cheese grater effect is that there is the first trial in this SBG PCI is saphenous vein de novo. It's there in that article if you remember. Basically, it's a saphenous vein de novo. Yeah, where they have compared stenting or just doing a balloon angioplasty of SVG, and they found that stenting had higher distal embolization than actually balloon angioplasty. So the reason why that happens is something called as cheese grater. All of us know what is cheese grater. So where we basically shred all vegetables or even like cheese in the US. So what happens is when there is a friable, so in a normal in a normal artery, the fibrous cap is well formed. So there is not much of this cheese grater effect, that there is no increase in distal embolization or distal embolic particles after stenting. But in SVG, because of the friableness and lack of collagen, what happens is that once we stent through the portion of the stents, the tissue which protrudes is basically not just protruding, it actually distally embolizes. So to prevent that, they say that you have to use exactly 1:1 balloon and also stent sizing if you were to choose stent sizing, and stenting is any day better than just ballooning. That is proven beyond doubt. And of course, like you said, wherever possible to use an embolic protection devices, especially this thing. Just GP2B3A, Gaurav, actually it's not like they didn't find benefit in the EPIC trial and other trials. They did find benefit. There was definitely decreased embolic. There was decreased infarct. There was decreased
of embolic episodes, no reflow phenomenon, all those improved. But in safer trial, they found that the people who used GP2B3A had higher mortality. Since then, they have made it actually a class 3 recommendation. There's no explanation as to why, but then they did find a specific multivariate analysis independent predictor of mortality in safer trial was using this thing.
Okay.
So after that trial, basically GP2B3A went out of phase because this thing. Why thrombolysis will not help much in SVG graphs? Any difference in thrombus or something? No, funny. Mainly the thing is the like Gaurav was saying, it's better. They have found that there are better outcomes in a patient who has presented with MI in a PCI capability setting if the anatomy is defined. That's what is the usual thing. Which I mean, if let's say SVG graft is occluded, it usually causes unstable angina, but less times STEMI. But it can cause STEMI also, but less common. It usually causes angina on exertion or unstable angina bar STEMI. So STEMI in an SVG graft occlusion is little rare. That's why they don't generalize thrombolizing after a CABG unless we are very sure that it is only RCA, like there is no collaterals, something like that. And if your PCI is going to take a long time. Anyways, with that I'll stop. I think Mautika.
This thing, I think Mautika had asked one doubt. See, Mautika, this thing, they have tried anticoagulation. They found that the bleeding was much higher. And in COMPASS trial, in fact, there was a subset of patients post CABG PCI where they tried rivaroxaban in along with aspirin, and they didn't find any benefit. They rather found that those subsets had higher bleeding events. So after that, there was ample evidence to say that there is no role of anticoagulation until the patient has some other indication like a mechanical valve or AF or anything. So apart from that, anticoagulation is not recommended.
Gaurav, regarding one more thing, like post CABG, if a patient has an acute infarct, for example, RCA territory, and if you want to do angio, like during hooking, there are high chances that anastomosis can get compromised. Is there any such data?
Your voice is breaking, Venki.
So, for example, patient post CABG, patient had an acute infarct during in post-operative period itself, and when you want to take the patient for angio, and when you are doing, like, for example, SVG angio, is there the chance of graft adhesions at the anastomotic site, like
graft adhesions?
You mean proximal anastomotic site, Venki?
Yes, proximal.
I don't
know.
That
is why they say that you should use. There is some mention in Topol also in these articles that you should use shorter guides and there should not be deep intubation and all those things. But there is a possibility. But then again, this is something that you can't avoid. Okay. So they in fact, Topol has one diagram where they say that according to the vessel takeoff, how the graft is taking off from the aorta, according to that you choose a catheter. So they in an acute, like upward bend and take off, in that they say hockey stick or AL1 should be preferred, and where there is a direct gradual downward bends,
no Gaurav, his doubt is whether trying to hook a graft will actually increase its dehiscence. The answer to that is actually that basically if you are not able, you should use a general non-selective shoots generally to try and locate them. And like I told, basically the general this protocol, because it is difficult to hook, they generally follow this protocol. Right side is just above the right coronary artery, left side is in the order of LAD diagonal followed by obtuse margle. Yeah, for SVG grafts. Of course, if you're using a Lima, you don't need all
my doubt is, like, if there is that chance of some anastomotic side injury, then what is the, and you're not intervening with the PCA in acute setting most of the times. What is the role of emergency angio in acute post CABG like infarction? And you're anyhow not going to redo CABG because of high mortality and morbidity which you have got.
No, like I said, STEMI post CABG because of an acute thrombotic occlusion or abrupt cutoff of SVG is very rare. I mean, it's less common than NSTEMI bar stable CAT presentations. So acute thrombotic closure usually happens within the hospital itself. So that is usually silent. Nothing happens because of that. Like, like we know that 12%, 10 to 12% will close up even before he exits the hospital. So that doesn't cause a clinical event usually, but
only 3% of those cases have clinical.
Yeah. So what you will come across is something with a stable CAD or unstable angina bar and STEMI, where they recommend usually doing a CT-CAG nowadays generally because of all this, because the registry showed that there is a higher complication with the redo CABG in most of the times because of a contrast induced injury in trying to search for the graphs, and also trying not prepared for it, which was much lesser. And also the advantage of CT-CAG is that venous graphs are bigger, so they are well seen, and there is less motion artifact. There is no motion only. There is no vasomotion effect and no movement with the cardiac activity. So there is no movement artifact. So lesser gating related artifacts will also be seen in venous graphs. So CT-CAG is very superior compared to actually just going in blind in trying to plan a procedure if it is a very stable patient post CABG. Mautika, I think you can start. We'll have one more topic also.
Yeah. Am I audible?
Yeah.
Hello. Am I audible?
Yeah.
Audible.
Yeah, fine. I think my screen is clear. Okay. Thanks, Gaurav, for answering the question. And we'll be going ahead with the role of beta blockers in myocardial infarction. I just want to give a brief about the beta blockers. I mean, before going into it, first to start with the beta receptors. As all of us know, there are 3 types of beta receptors: beta 1, 2, 3, and these are the locations of these beta receptors. I mean, the main concentration of these receptors vary from organ to organ, and we are mainly concerned with beta 1 receptors, which are concentrated in heart. So beta 1 receptors, they are G-protein coupled receptors basically. And the main difference between the beta 1 and other 2 types of beta receptors is that beta 1 receptors are exclusively G alpha stimulatory coupled receptors, whereas beta 2 and beta 3 are both inhibitory as well as stimulatory. Why this is important is that under stressed conditions, there is alternation in the G protein that is bound to the beta receptor, and based on which, whether it is stimulatory or inhibitory beta, this G protein which is bound to the receptor, the downstream effects vary. So moving on, this was a classification, as all of you know. This is a classification given to the beta 1 receptor blockade, and they are classified into first generation, second generation, third generation based on the vasodilatation, presence of vasodilatation, and selectivity to the beta 1 receptor. And we are more concerned with the presence or absence of intrinsic sympathomimetic activity, because in patients with myocardial infarction, it is recommended that we should not give beta blockers with intrinsic sympathomimetic activity, because they have found to have more arrhythmogenic potency. So actually, I just wanna give a brief account on the methods to titrate the beta blockers, but the evidence in ACS per se for beta blocker up titration I couldn't find, and whatever the beta blocker up titration methods followed for heart failure has been adopted even in patients with ACS. So this is the this is the protocol. This is the protocol which is used to uptitrate the beta blocker dosage, and I'll deal with the duration of beta blocker in next few slides. But this is in brief about the beta blockers what we use in patients with ACS, and they are like only 3 which have been studied, and the evidence is available only for 2. That is for metoprolol and carvedilol, but propranolol and atenolol were used before, but they are not used anymore. And for bisoprolol and nebivolol, whatever the evidence for heart failure is carried on to the ACS. So to begin with, metoprolol is started as an initial dosage of 12.5 to 25 milligrams, and it has to be targeted to a target dose of 200 milligrams daily. Whereas all of us know the carvedilol has to be started from 6.25 mg BD to 25 milligrams BD. And moving on quickly to what exactly is the role of beta blockers in patients with acute myocardial infarction. Basically, this topic is dealt as in like in the pre-reperfusion era and the post-reperfusion era, because there are very few indications for beta blockers per se when it comes to the survival benefit in patients with myocardial infarction. So I'll deal this topic in that perspective. To begin with, I just want to give a few account on the pathophysiology and where exactly the beta blockers have a role, like in acute myocardial infarction. It was found that it was hypothesis that in acute myocardial infarction, beta blockers actually decrease the size of the infarct, and thus they have found to have, they thought that it would have some early mortality benefit when it was started early, and it also decreases the risk of death. The mechanism of action which they have proposed for this is that usually in myocardial infarction, there is a catecholamines storm, which leads to increased myocardial oxygen consumption, increased myocardial necrosis, and decreased fibrillation threshold. And the beta blockers, they come into play in these areas, that is by decreasing oxygen demand, via decreasing heart rate, blood pressure, and contractility, and by decreasing the VF threshold, by increasing the VF threshold. So the VF incidence is decreased and the incidence of sudden cardiac death is increased. And by decreasing the automaticity, they have found that by decreasing the conduction system velocity, beta blockers were found to have decreased automaticity. And by causing decreased heart rate, not only they decrease the myocardial oxygen consumption, but also they increase the duration of the diastole, wherein the coronary perfusion is improved. And they also was thought to have some role in the remodeling and thus improving the LV function, wherein they have found that the infarct size and even the timing of the treatment with beta blockers were thought to have some role. But there is various conflicting evidence for all these. I'll go through that. And they have also found that it can improve the LV diastolic function. And even they have some studies have shown that there is ios-proven decreased atheroma volume, and thus decreasing the progression of coronary artery disease is what they found with beta blockers. And the important mechanism at the level of metabolism is that beta blockers, by inhibiting the lipolysis, they actually decrease the free fatty acid levels in the blood, and whereby the free fatty acid availability is decreased. And as all of you know, the free fatty acids are the chief metabolic substrates for myocardium in a normal state. But the energy efficacy with free fatty acids is very low, and that is the ATP production at a compromised myocardium cannot be done with free fatty acids. And it is beta blockers, by decreasing this availability of free fatty acids, they change the energy substrate from free fatty acids to the glucose, thus decreasing the oxygen consumption by the myocardium. And there are some membrane interaction related effects but thought to be proposed for some of the beta blockers like carvedilol and nebivolol, which is not as such related to other effects of beta blockers. And they found that these two might have this platelet inhibitor action, and they also found that they could inhibit the neutrophil recruitment into the site of injury, thus decreasing the inflammation. So quickly moving on to the indications. What exactly are the benefits with beta blockers in myocardial infarction? As I told you that in the no reperfusion era or pre-reperfusion era, where the usage of DAPT, AC inhibitors, ARBs, and mineralocorticoid receptor antagonists and statins were not that great, whatever the benefit found in patients with myocardial infarction was found with beta blocker usage. But with the onset of increased usage of fibrinolytic therapy, primary PCI, and all, the actual benefit of, or the survival benefit of beta blockers has been challenged, and it has been studied in many of the studies. And in the fibrinolytic era, there was no quality evidence for long-term beta blocker usage, and the results were like they are not superior. They are equal to, or there is no survival benefit per se with beta blockers, even in the fibrolytic therapy era. So now we are in the primary PCI era. The benefit of the beta blockers is mainly reduced to improved outcome because of the revascularization, what we are commonly doing. And the observation studies says that, sorry. Yeah, and in some of the observation studies, the beta blockers usage at the time of discharge have found that the all-cause mortality at first year of follow-up has decreased. And I'm telling you, this is an observation study, and it has been challenged in many of the randomized control trials. And in preserved LV function, and there was found to have no benefit even at 1 year of follow-up, even in these individuals after primary PCI. Whatever the findings in observation studies that they found to have a benefit at 1 year was only for the individuals with acute MI and reduced LV function, not for individuals with normal LV function. And the initial therapy for beta blockade, when there is no contraindication, all the patients with myocardial infarction have to be treated within 24 hours after the diagnosis of myocardial infarction. And the indication for IV beta blockers is reserved for only few scenarios, that is for patients with refractory angina and patients with hypertension, wherein hypertension has been shown to be or has been proven to have been related to ongoing ischemia. And even in these individuals, we can give beta blockers only if we have ruled out a hemodynamic instability, shock, acute or over decompensated heart failure, and conduction system blockade. When these things are not present, and when the patient is having refractory angina or hypertension related ongoing ischemia, then only there is a role for IV beta blockade prior to PCI. And some of the evidence during the fibrolytic therapy comes from the COMET trial, which is a very big trial, also known as Chinese cardiac study 2, because 45,000 patients have been studied in this trial, and it is a 2x2 factorial design, wherein metoprolol and clopidogrel has been studied versus a placebo, wherein 50% of the individuals underwent fibrolysis, and they found that there was no benefit with early IV beta blockade therapy in individuals. I mean, this I'll tell you why, because they have found that there is 30% increased risk of cardiogenic shock in individuals who have been given early IV beta blockade. And the fallacy in the study is that they have given IV beta blockade even for the patients when CALIP class 2 or more. So they have done a sub-study analysis, that is the low-risk sub-study analysis of COMET study, and they have found that in low-risk patients, that is who are not in cardiogenic shock or who are not in hypertension or there is no tachycardia at presentation, if they have been, if they have been taken as a subset, they have found to have some benefit with early IV beta blockade, and this was comparable to that of the pre-reperfusion era studies like Miami and ISIS. These were the big studies prior to reperfusion era. And the COMET study with this low-risk subset has found to have equal role, like that it was found to have some beneficial role in low-risk subset, the IV beta blockade. And so since there was, it was not showing, it was not guiding whether to give IV beta blockade or not. There was the 3 more studies have been conducted. Like one of such study is the TIMI-2B study, wherein the early IV metoprolol versus delayed oral metoprolol have been studied, and they have found that there was decreased mortality by the end of 1 week in low risk group. And these other 2 studies which I've been mentioning, like this Metacard Civic and early BAMI, they have actually studied for IV beta blockade and the improvement in the LV function and the infarct size. They have actually looked for an objective evidence of decreased or decreased necrosis and the actual benefit objectively have been studied in these two studies via cardiac MR. These two studies, they did cardiac MRI after reperfusion, and the Metacard Cynic have found that there is benefit at 5 to 7 day. There is benefit in the MRI studies, that is that the infarct size have been reduced. But the major fallacy with this study is that it is not a placebo controlled study, and the infraval MI were excluded in this study. But still, whatever the recommendation now we have for early IV beta blockade for those reserved category of patients, like I said, refractory angina and all, the evidence comes from this study only. And although there are some fallacies, there is another study to quote the early beta blockade benefit, that is the Cadillac study, wherein the pre-procedural beta blockade has led to lower mortality in patients who were initially not on oral beta blockade. That is important. And moving on to what is the choice of beta blocker that we have to give in individuals, and what is the route that we have to give. It was found that oral beta blocker therapy is always superior to IV. And as I told you, there are very few indications for IV beta blockade. And it is always advisable to give cardio-selective beta blockers rather than non-selective beta blockers. And it is always advisable to start with a short-acting beta blocker and go for rapid titration. And at the time of discharge, the short-acting beta blockers have to be converted to the long-acting beta blockers. From the available evidence, the IV regimens were proposed for metoprolol, atenolol, and esmolol. So these were the proposed IV regimens for metoprolol, atenolol, and esmolol, and I think you can go through it. And whatever the evidence that has been quoted till now is only for the metoprolol. And what happens to the other categories of beta blockers like carvedilol, bisoprolol, and nebivolol? But the available evidence for MI per se has been found there only for carvedilol, apart from metoprolol. And carvedilol has been studied in two studies, that is in the Capricorn study and the CAMI study. The only difference between these two is that in Capricorn, they have studied MI patients with EF less than 40%. Whereas in CAMIS, it is a study which was done on MI patients with normal LVEF. What they have found in Capricorn study is that with carvedilol, that is early initiation of carvedilol within 24 hours of the onset of the symptoms, after a follow-up of 15 months, they have found that there is decrease in all-cause mortality. But what they have done is they have studied with 6.25 mg to start with, and they have titrated to 25 milligrams BD over a period of 4 to 6 weeks. And whereas in CAMIS, they have compared carvedilol with atenolol, and they have found that there is no superiority of carvedilol over atenolol, and both were found to be equally efficacious. And there is another study for role of beta blockers in normal LVEF following MI. They have found that there is a Gulf Coast study. They have found that when the patients have been discharged with beta blockers when they have been followed up at 1 month, 6 months, and 12 months, they have found that the protection whichever has been conferred by the beta blockers was there only till 1 month. That is, there is only short-term benefit with beta blockers in individuals with MI and preserved EF. But they didn't find any benefit at 6 months and 12 months follow-up in terms of mortality or reinfarction or stroke. So this is another new study which was published in 2019, which was showing only a short-term benefit with the beta blockers in normal LVEF. What happens to the long-term? What does the guideline say? Like, can we give long-term is how long we give beta blockers, and we can can we give it lifelong, or there is any particular recommendation like following MI? The AHA says that for secondary prevention in patients with ACS with normal LV function, the duration they quote is for 3 years. It's a class 1 recommendation. And if at all you want to continue beta blockers for more than 3 years in normal LVEF, it is a class 2A recommendation. Whereas for reduced EF, we have to continue beta blockers lifelong. I mean, as long as the EF is low. Whereas according to ESC, they didn't mention any particular duration for which it has to be continued. And they say only that in patients with LV dysfunction, beta blockers have to be continued indefinitely. So moving on from ACS, that is STEMI, NSTEMI, and unstable angina group to a stable CAD group. What is the role of beta blockers in stable CAD? So this has been studied in REACH registry, where that is the reduction of atherothrombosis for continued health registry, wherein more than 45 years age group patients with established coronary artery disease and peripheral vascular disease or cerebral vascular disease have been included. And they have actually categorized the patients into 3 groups. That is patients with known prior MI with as one group. The second group being with the CAD without known MI. That is people who have been diagnosed to have coronary artery disease on a screening basis. And the third group being those patients with risk factors alone without any documentation of coronary artery disease. And when they have been studied and followed up, they have found that the beta blocker use was not associated with any lower incidence of cardiovascular events among the individuals, even with prior history of MI or no MI with screening diagnosed CAD, or in those with risk factors only. So according to this, there is no role for beta blockers in individuals with stable CAD except as an anti-anginal therapy. So, moving on to the dosage of the beta blockers that has been advised in myocardial infarction. There is this recent study that is obtained, which actually have studied that is what dose of beta blocker is optimum. Like even though because in routine clinical practice, we won't be titrating the patients to the targeted dose which have been studied in the randomized control trials, and they have been always undertreated. And that's why the study has been conducted, and they have found that there was no survival benefit in patients treated with beta blockers to the doses that have been used in randomized control trials. That is, whatever the tolerated dose the patient can take, that dose is enough to have a benefit in that individual. You need not titrate the dose which has been mentioned in the randomized control trials. Like that's what has been found in uptime trial. And is there any specific agent like one is superior to the other? Like till now they have not found any head-to-head superiority of one agent over the other. And the beta blockers as such have a class effect. And what is advised is we have to go for an agent which doesn't have intrinsic sympathomimetic activity. And they found that even there is no difference in benefit with the cardioselective versus non-cardioselective drugs. And the most commonly used agents in our clinical practice being metoprolol and atenolol. And the evidence was found that carvedilol, metoprolol succinate, and bisoprolol were found to have survival benefit in patients with reduced ejection fraction following MI. So after all these studies, these were the recommendations which has been proposed for the usage of beta blockers, that is in ACS or in stable CAD. In patients with ACS, that is in STEMI, oral beta blockers has to be started in the first 24 hours in patients with STEMI who do not have any of the following contraindications, that is being signs of heart failure or evidence of low output state, or increased risk of cardiogenic shock, like patient being more than 70 years, systolic blood pressure less than 120 millimeters of Hg, or sinus tachycardia or bradycardia, or increased time since the onset of the symptoms. So when any of these things are not present, these individuals have to be started on oral beta blockade within first 24 hours of onset of symptoms. And the relative contraindications for the use of oral beta blockers being PR interval prolongation of more than 240 milliseconds, presence of second or third degree block, and presence of an acute exacerbation of asthma or reactive airway disease. The other two class 1 recommendations for beta blockers in STEMI being that beta blockers should be continued during hospitalization and after hospitalization when there are no contraindications to the specified duration which I have mentioned. That is, if there is normal LV function for 3 years, if there is reduced LV function, it has to be continued till the LV function normalizes. And in patients who had initial contraindications, which I have mentioned the 4 of them, at the time of presentation or before 24 hours after onset of the symptoms, they have to be reassessed. And if at all they no longer have those contraindications, they have to be started on beta blockers and then they have to be discharged. And in patients with NSTEMI and unstable angina, the class 1 recommendation for beta blockers or being like early initiation of beta blockers is recommended in patients with ongoing ischemic symptoms in the absence of any other previously mentioned contraindications. And it is recommended to continue chronic beta blockade unless the patient is in KILIP class 3 or high. So how are we titrating it? Like it has to be titrated with the heart rate, and the goal of heart rate being the heart rate at rest should be maintained between 55 to 70 per minute, whereas in for stable CAD, for control of angina, they mention it is between 55 to 60, but it is almost the same. And the blood pressure should be maintained more than 90 millimeters of Hg. That is very important. And as I mentioned, the contraindication for beta blockers being these, like absolute and relative. But what they say is, even in individuals with relative contraindications, like the comorbidities like COPD, asthma, and acute decompensated heart failure, and diabetes and peripheral arterial disease, even in these individuals, some of the studies have found to have some survival benefits. So after acute event has been taken care of, there can be tried to put beta blockers in these individuals. So to summarize, these are the only 5 things which we have to remember for beta blockers in ACS. That is, the beta blocker should be given to all MI patients with heart failure and an EF of less than 40%. If the patient was in active heart failure at the time of diagnosis, the initiation of beta blockers have to be delayed. And since in these individuals we have delayed the we have delayed the beta blockade, we have to reanalyze them before discharge, and we have to start the patient on beta blockers and discharge. All MI cases, it has to be initiated within 24 hours if no contraindication, and the optimal duration is not known, and whatever the duration they have thought to be of benefit is for 3 years in normal LV function, and the target heart rate should be maintained between 50 to 70, and the absolute contraindication being cardiogenic shock, bronchospasm, and heart block, and decompensated heart failure. So this is very brief, like about the beta blockers in ACS. Hello? Hello?
Yeah, you are audible. Nice presentation.
Yeah.
Thank you.
Thanks.
Quite to the
doubts?
point. Mautika, any idea why this ACCHA are telling that beta blockers with normal EF post MI should be continued for 3 years? Any randomized trial is giving this evidence?
Actually,
they found in the post MI trials, like though Capricorn had actually included only less than 40, there was a similar parallel study with that, and a lot of meta-analysis which have been done by this Bangalore. There's one guy called Sripal Bangalore that guy has done a meta-analysis. Both these have shown that at least till 3 years there was some benefit, but then beyond that we don't know. So that's the kind of
So no RCT evidence, but some meta-analysis with some many. Okay,
yeah.
fine.
They say that there was consistent benefit at least for 1 year for the first year of MI, they found consistent benefit, and they have given this arbitrary value of 3 years. That's what I told you. Like there was no evidence for that.
Okay. Thank you. Because ACC usually are conservative while prescribing the number.
See, but if you look at it, Varshit, actually, like let's say patient has undergone MI and patient has recovered LV function, because reduced LV function, we are anyways giving beta blockers. So now after 1 year, we are thinking, so now according to the ESC new chronic coronary guidelines, he comes into a chronic coronary syndrome post 1 year after an acute event, among those 6 chronic coronary syndromes which they have mentioned. So if you call him a chronic coronary syndrome starting from his post 1 year, then he would require it if he has an angina or if he has a heart rate of more than 80. So both of these are very common scenarios for a patient who is with an improved LV function also. Most often they tend to have a heart rate of more than 80, or like, they might have some angina. So both these are very common indications why beta blocker would stay on in their recommendations. So after that, there is no mortality benefit which is proven, but then for symptomatic benefit, it is indicated. Even the AHA guideline says that it is to be given for patients who have angina or continue to be a choice of an antihypertensive. Sorry, I forgot to mention even hypertension. So along with this thing, like, after the LV has completely remodeled, they say that basically this is not in MI, in patients who have had a DCM with ADHF. Mainak, you can load by then. I will just complete this.
Yeah, I'll just.
Yeah. So in patients with in patients with ADHF who have had a recovered LV function, there is a study and enough evidence which says that beta blockers, like leaving it on versus actually tapering and stopping it, they found that there were increased number of rehospitalizations in people who have actually discontinued it. That is in DCM, not in post MI. So extrapolating all this data, and also fact that they will be having either heart rate more than 80 or have symptoms of angina or be hypertensive while on a ACE inhibitor, the chances are that they will be on beta blocker than not.
Okay. Dimpu.
Gautam?
ಇಲ್ಲ ಅಂದ್ರೆ ಈಗ ನಾವು ಆಫ್ಟರ್ ಎನ್ ACS event, and actually I didn't hear to the last part of the seminar. Still I'm asking ಅದೊಂದು doubt ಇತ್ತು. After an ACS event, EF is more than 40.
Yeah.
Okay, and say that he doesn't have hypertension or angina, nothing.
Okay.
So then the beta blocker is class of indication what here in that case?
According to AHA, for 3, if you are saying EF is more than 40,
Yeah, more than 40.
More than 40, there is no definite benefit beyond 1 year, but they say you should give it at least till 3 years. That's what AHA says. But according to ESC guidelines of STEMI, if you see, it is 2A indication. It is class 1 if it is less than 40. If EF more than 40, it doesn't say class 3, it says 2A.
2A, no? Okay.
Yeah, it says 2A. Yeah, 2A. Both in patients who have undergone a PCI or fibrinolysis post STEMI, if EF is more than 40, it says 2A indefinitely. It doesn't even give that recommendation of 3 years.
Yeah.
ACC for 3 years it has, no? It is as a 2A or 1?
That is 1.
If it is more than 3 years, if you are considering to continue beta blockers, it is a 2A indication.
Up to 3 years, 1, no? Class 1.
Up to 3 years, it is class 1, yeah.
But they don't classify it based on EF. But ESC, on other hand, in the 2015 STEMI guidelines, it is given. For PCI, in that flowchart, it will be given. Like, for PCI patients or like fibrinolysis arm, you can actually give it. If it is less than 40, it is class 1. Less than more than 40, it is 2A class.
Yeah, thank you.
And one more thing, they might just mentioning it in passing. Basically, nebivolol, all of us know, has some vasodilatory action. So nebivolol does not actually convert into nitric oxide synthase or actually increase the NOS. It's basically beta blockade at beta 1, and it has an agonism. It has a beta agonist action at beta 3 receptor, which was actually recently described. Not recently, it is actually for the past decade or so it has been there. So beta 3 is a particular type of receptor which is actually present in cardiac myocytes, but is resistant to down regulation in heart failure. So as we all know, in heart failure, beta blockade is down regulated, but beta 3 is actually resistant to down regulation, and it has this survival effect, because beta 3 pathway is actually responsible for NOS production. So that pathway is actually activated by nebivolol. That is why there is some vasodilatory action. Mainak, I think you can start. Hello. मैंने खुद को म्यूट कर रखा है क्या? Hello.
Am I audible? Hello.
Yeah.
Okay. So renin-angiotensin system in cardiovascular disease, it has got a lot of aspects when you consider cardiovascular diseases, like RAS blockage as a primary prevention in high risk patients, or RAS as a role in hypertension, RAS blockage in heart failure with reduced ejection fraction or preserved ejection fraction, RAS in a patient of CAD, or the recent role of ARNI. And so coming to how the RAS renin-angiotensin system is actually causing the effects on the heart and and the vascular bed is, the RAS is stimulated when there is decreased blood supply to the kidney in the form of there is a low cardiac output state or hypotension, or there is hypovolemia. Also, if there is decreased reabsorption of sodium or decreased delivery of sodium to the distal tubule, which can occur in a patient who we are using loop diuretics, or we are decreasing the sodium intake in a patient with heart failure. Also, heart failure is a state of chronic sympathetic overactivity. So beta 1 mediated stimulation also increases the secretion of renin. The RAS system starts with the secretion of the renin from the JG cells, and this renin acts on the angiotensinogen, which is secreted from the liver, and it converts it to angiotensin 1. The angiotensin 1 in lung, and particularly in the lung and in other vascular beds also, is converted by angiotensin converting enzyme, which is ACE, to angiotensin 2, which is the word through which the RAS mainly acts. And angiotensin 2, you know, it is a potent vasoconstrictor. It causes cardiac remodeling and also helps in synthesis of aldosterone from the adrenal medulla. Now this aldosterone, what it does is it increases the sodium reabsorption from the distal convoluted tubules. It causes potassium depletion, and also it causes myocardial fibrosis. Now coming to the effect of angiotensin 2 on the different aspects, on the heart muscle, it causes myocardial hypertrophy and it causes interstitial fibrosis. In the systemic blood vessels, it is a potent vasoconstrictor causing hypertension, and also it increases the overload on the failing heart. On the coronary circulation, it acts as a vasoconstricting agent, and also it causes endothelial dysfunction to decrease the nitric oxide. It increases the oxidative state and causes a pro-inflammatory state locally, and it causes promotion of atheroma formation and plaque destabilization. In the renal circulation, it causes constriction of the efferent arterioles and increases the intraglomerular pressure, which is attributed to increase in proteinuria. It also causes glomerular fibrosis and increases sodium reabsorption from the distal convoluted tubule via aldosterone. Now, in the adrenals, it causes increased synthesis of aldosterone, and on the coagulation system, it increases the fibrinogen, it increases the plasminogen activator inhibitor 1, and relatively the inhibition is more than the activation of the tissue plasminogen activator. So the net effect it increases the sodium reabsorption causing volume overload, it increases the afterload, it decreases the coronary blood supply, it increases LV remodeling and interstitial fibrosis, and also produces a pro-inflammatory and pro-coagulant state. Now, coming to the effects of RAS inhibition, we see that we can block RAS at different levels. The main blockage is at the level of the AC inhibitor, where the conversion from angiotensin 1 to the angiotensin 2 is happening, by AC inhibitor we can block this effect. Angiotensin 2, we can block the receptors where angiotensin 2 is working by ARB and ARNI. By spironolactone and eplerenol, we can block the aldosterone action, and also we can directly block the renin when there is by aliskiren. Now the net effect will be there is decreased sodium reabsorption and volume overload state. There is decreased afterload on the failing heart. The remodeling also decreases. Now another thing is that during heart failure there is volume overload and myocardial stress. Sorry, it is not stretch, it is stretch. Myocardial stretch, which causes increased secretion of natriuretic peptides, which has got all three types, which is ANP, BNP, and CNP. And all these three types of natriuretic peptides at alpha carboxy terminal peptide. Now, the synthesis comes from the volume overload and myocardial stretch stimulus, and also by the response to neuroendocrine upregulation in heart failure. These natriuretic peptides are helpful in the form of it causes diuresis and natriuresis. So it decreases BP, decreases volume overload, and decreases afterload. It increases production of NO, causing relaxation of the vascular smooth muscles. Vasodilatation of the renal bed increases the blood supply and decreases renin synthesis. Directly by acting on sodium channels, it can cause natriuresis. It may reduce the transforming growth by TGF beta, and so it is a which is a pro-fibrotic molecule, and thus TGF beta as it reduces, so it decreases the fibrosis also. But it is an unstable compound. It is cleared out from the circulation by proteolytic cleavage, where this alpha carboxyl terminal peptide is removed by an enzyme which is known as neutral endopeptidase and or neprilysin. Now, but this neprilysin inhibition also causes degradation of angiotensin 1, angiotensin 2, endothelin 1, bradykinin, substance P, and adrenomedulin. So neprilysin inhibition is causing a beneficial effect by increasing the natriuretic peptide effects. But on the other hand, it also causes increasing angiotensin 2, endothelin 1, and angiotensin 1. So the neutralization benefit of natriuretic peptide augmentation can be prevented by increase in this angiotensin 2 level and endothelin 1 level. So we usually combine an ARB to overcome this neutralization effect. However, if we combine an AC inhibitor with a neprilysin inhibitor, it increases the bradykinin level also. So more vasodilation, more hypotension chance, and more chance of angioedema. This is also the thing that AC inhibitor should be stopped at least 48 hours before we can start an ARNI. Now, coming to different roles of RAS inhibition in cardiovascular disease, AC inhibition in primary prevention in high-risk patients has been studied in different trials, of which I will mention HOPE, Europa, and PEACE trial. Now, the study population was almost similar. They included a patient who has got a vascular territory involvement. Like in HOPE trial, age of more than 55 years was taken. History of any coronary artery disease, stroke, peripheral arterial disease, or diabetes with one or more complex risk factors like smoking, microalbuminuria, hypertension, or dyslipidemia. In Europa trial and PEACE trial, only the stable CAD patients were taken, and they included the patients with MI of more than 3 months, where revascularization of the coronaries was done more than 3 to 6 months. CAG was done to describe that there is a stenosis of more than 50 to 70%. And in Europa trial, positive stress test in males was also considered. They excluded any effect which has already have occurred due to any insult to the heart or to the kidneys. Like heart patient is having heart failure, LVF of less than 40%, uncontrolled hypertension, myocardial infarction, or recent stroke, recent myocardial infarction, or recent revascularization. Or the patient has got overt nephropathy in the form of increased creatinine more than 1.7 to 1.2, more than 1.7 to 2, or there is hyperkalemia where you cannot use an AC inhibitor. Now the follow-up was all the studies was around a mean of 5 years. In P study, we found that there is a significant there is a fall in the CV outcomes, but it was non-significant. But however, in HOPE and Europa trial, we found that 80% reduction in the combined outcome of CV death, non-fatal MI and stroke was there with using SE inhibitor. The drugs which were used was ramipril in HOPE trial with titration to 10 mg OD. Europa trial, perindopril was used, and in PEACE trial, trandrolapril was used. There was drug adherence to the medications in more than 80% of the patients, and there was no significant difference in the outcome when we consider low risk versus high annual CV risk. Revascularization was done or not, or the patient was on optimal medical management with aspirin, statin, and beta blocker optimization, and whether there was hypertension was present or hypertension, or the patient were not hypertensive. So we can conclude that irrespective of the hypertension, there is a primary effect of SE inhibitor, which was seen to decrease the CV outcomes in patients who has got any form of disease in the vascular bed. Now, can we use ARBs also in these patients? Or whether we can get a similar outcome like SE inhibitors? It is seen that the effect between SE inhibitor and ARB is almost similar, that angiotensin 2 we are blocking, but SE inhibitors as an additional kinase 2 inhibition, so bradykinin level rises. Though the complications like increased hypotension and angioedema is there, but there is a beneficial effect of bradykinin in the form of NO release and prostaglandin mediated vasodilatation. So the two studies were done. One was on-target trial, which was done between telmisartan and ramipril, and it was found that telmisartan was non-inferior in the terms of outcomes in these patients who have got no evidence of heart failure. And also it was beneficial, and it did not produce any cough or angioedema. However, when we studied telmisartan versus placebo, we found that there was the patients who was included had well-controlled blood pressure, and there was high use of statins and control of other CV risk factors. And we found that telmisartan did not show any significant benefit compared to placebo. However, SE inhibitors had got some effect compared to placebo in HOPE and Europa trial in primary prevention. So the take-home message is in primary prevention in the role of SE inhibitor and ARB is the effect of ARB is primarily driven by the control of hypertension. SE inhibitors along with control of hypertension also has secondary beneficial effect on CV mortality and other adverse outcomes on the top of decreasing the blood pressure. First choice in patients with a vascular disease for primary prevention will be a SE inhibitor. If the patient is not tolerating SE inhibitor, we can use an ARB. Now coming to RAS inhibition in patients with hypertension. We know that the first line drugs for the control of hypertension include the SE inhibitor or an ARB, CCB, and a diuretic. And in resistant hypertension, we can use an aldosterone also to treat resistant hypertension as an add-on effect, as an add-on agent, provided that the renal function is normal and there is absence of hyperkalemia. Now coming to 2017 ACC/AHA guidelines for hypertension control, target BP was 130/80, and in the patients with heart failure, reduced ejection fraction, preserved ejection fraction, diabetes, and diabetes with microalbuminuria, and in stable ischemic heart disease, SE inhibitors were the first line drugs. In case of diabetes, we can use all the three first line modality drugs, but if the patient has albuminuria, SE inhibitors force over other with a class 2B indication. Only thing is that if the patient has got bilateral renal artery stenosis or a stenosis in a single significant renal artery stenosis in a solitary kidney, we can use SE inhibitor or ARB, but we have to monitor the creatinine and the potassium level or any cause of increased hypertension in these patients, and that is we have to closely follow up this patient. If we can closely follow up, we can use in that set of patients also. The control of hypertension has shown a positive effect in reducing the CV mortality and CV effects, but majority of the studies has shown that there is non-significant reduction in this form of CV events. The older studies coming to reduction of stroke, there is a significant reduction of stroke in these patients with control of hypertension. Progress study and Accord study had showed that In progress study, perindopril was used, and in accord study, a number of combination medications were used, and it was seen that control of hypertension reduces stroke in these patients. Now, on target and detailed trial, which was the on target trial, I have already discussed. Detailed trial was done in diabetic kidney disease patients, and both ACE inhibitors and ARB are effective in reducing the CV events and mortality. However, in patients where we start upfront perindopril, it was studied in ASCOT, BPLA, Advance, and IVETS trial, and it was found that significant reduction in CV mortality was there with control of hypertension by more than 20%. Coming to resistant hypertension, aldosterone antagonist in the form of spironolactone eplerenone, low dose was used to control this as an add-on effect agent to control the hypertension in this patient, and it was found that mineralocorticoid receptors receptor antagonists were twice more effective than alpha-1 blocker and bisoprolol, and it was the outcome was seen in pathway 2 trial. Now coming to RAS inhibition in heart failure with reduced ejection fraction, this is the main aspect of the thing, and it's found that AC inhibitors and ARBs both are effective. Captopril, both are effective, and ARBs are non-inferior to AC inhibitors. Now, how they act is that it decreases the conversion from angiotensin 1 to angiotensin 2. It decreases the kinase 2 level, so upregulation of bradykinin is there. The ultimate effect is there is decreased volume overload by decreasing sodium reabsorption. It stabilizes the LV remodeling, and it causes afterload reduction in a failing heart, and also decreases the pro-inflammatory state. The overall benefit is that it has got a symptomatic benefit with improvement of NYHA class. It decreases the progression of heart failure. It prevents hospitalization from heart failure, and it has got a mortality benefit. The prerequisites to start a AC inhibitor in a patient with heart failure is that the patient should have a systolic blood pressure of more than 90 millimeter of mercury. There should be adequate control of the volume overload state by the diuretics. Otherwise, the AC inhibitors will not act. There is decrease, and we have to decrease the diuretic dose when we start the AC inhibitors, particularly if the patient has got dyselectrolytemia in the form of hyponatremia, hypokalemia, hypomagnesemia, the patient is having hypotension when we start the AC inhibitors, or there is worsening renal function when we start the AC inhibitors. Coming to the serum creatinine level, it is told that serum creatinine level of more than 2.5, we should wait before starting the AC inhibitors. And in this case, where we cannot start, we can use hydralazine and nitrate combination as a vasodilator. But there is no mortality benefit with these two drugs. And the patient should not have any hyperkalemia before we start. The starting that we should start at a low dose with 2.5 milligram of ramipril OD or a 2.5 milligram of enalapril BD, and we uptitrate it to the maximum tolerated dose. Every 3 to 5 days, we can increase it if the patient tolerates, with close monitoring of blood pressure, including postural hypertension, is there or not. We should monitor the renal function and potassium level every 1 to 2 weeks after starting and after uptitration of these AC inhibitors. Abrupt withdrawal should be avoided as it can precipitate heart failure in these patients. Potential side effects and remedies of these side effects are that the patient can have hypotension, and particularly if it is accompanied by dizziness, it is significant in this case. Renal dysfunction becomes severe, or there is progressive decline in the renal function. We find a delta rise of creatinine of more than 0.5 milligram per DL. We should assess the volume status of the patient. If there is no volume overload, we can decrease the dose of diuretics and monitor the patient for the improvement of the renal function. If there is a volume overload state, we will decrease the AC inhibitor and increase the diuretics in this case. Coming to other complications, there is AC inhibitors can cause hyperkalemia, and we should see that whether the patient is on any potassium supplements. We should stop the potassium supplements. We stop the mineralocorticoid receptor antagonist, and we correct the hyperkalemia. We see the response to the above measures. If still the response is not there, then we decrease the AC inhibitor dose. And if the patient cannot tolerate AC inhibitor, we can use a hydralazine nitrate combination in these patients. The AC inhibitors are well known for producing dry cough, and it is found in 10 to 15% of the cases. And the dreaded complication like angioedema can cause in 1% of the patients. And it is mainly bradykinin induced, and bradykinin causes vasodilatation. One, it can cause hypotension, and two, due to substance P release, it can cause increased capillary permeability and cause angioedema. Now, the evidence for use of AC inhibitors in the patient of heart failure with reduced ejection fraction came from the following trials, where enalapril was studied in consensus 1, where we use enalapril in patients with NIH class 4 patients, and there it was found that 12-month follow-up there was decreased mortality by 30%. In SOLVE trial, we used enalapril in a patient with a low NYHA class, and when SOLVE ASX was analyzed, it was found that in patients with NYHA class 1 and class 2, there was no mortality benefit with enalapril. However, in patients with post-myocardial infarction, irrespective of the NYHA class, SAVE trial with captopril, AIRE trial with ramipril, and tandraulapril was used in TRACE trial, and there was a mortality benefit of more than 20% in these cases at 12 months follow-up. Now coming to AC inhibitors versus ARBs, whether ARBs we can use in patients with who are intolerant to AC inhibitors in the terms of cough or there is angioedema. Now, studies have shown that valsartan and candesartan are non-inferior to AC inhibitors in preventing mortality. Coming to individual drugs, when the drug was studied studied against placebo, it was seen that valsartan in VAL-HEFT trial, there was decrease in the all-cause mortality. In CHARM trial, candesartan showed a decrease in the all-cause mortality, and in HEAL trial, losartan showed that with uptitration of losartan, there was decrease in the heart failure admissions. But overall mortality and heart failure admission, if we take as a composite outcome, it did not differ. Now, for non-inferiority of AC inhibitors and ARBs, it was shown in Valiant trial and Valiant trial, in which valsartan was compared with captopril, and there was non-inferiority in the terms of mortality reduction in these patients, and these patients were post-MI LV dysfunction patients. But it was seen that when we compare losartan with captopril, LI2 trial showed that losartan was less effective than captopril in terms of decreasing mortality. Coming to aldosterone receptor antagonist, indication for aldosterone receptor antagonist in a patient with heart failure is LVEF of less than 35%. However, in a patient post-MI, we use LVEF of less than 40%. Now, the patient should be symptomatic with NYHA class 2 or 2 class 4. Potassium level should be less than 5.5, and the creatinine clearance should be more than 30. Now, in this setup of patients, we found that adding a mineralocorticoid antagonist with uptitrating dose of spironolactone and eplerenol, there is a mortality benefit with mineralocorticoid antagonist, and there was also decrease in heart failure admissions. On top of the effect that the patient is already on AC inhibitor, diuretics, and beta blockers. The studies which prove the effect of the mineralocorticoid receptor antagonist are RAILS trial, where spironolactone was studied in a patient with LVEF of less than 30%, NYHA class 3, class 4. We have found that adding a spironolactone over AC inhibitor, diuretic, and beta blockers, there was more than 30% reduction in mortality and heart failure admissions. Eplerenol was studied in emphasis heart failure trial, where the patients with NYHA class 2, EF of 30 to 35% and QRS duration of more than 130 were taken as study population, and there was also 30% reduction in CV mortality, all-cause mortality, and heart failure admissions. Now, in post-MI patients with LV dysfunction, eplerenol was studied in emphasis trial, and there was 15% reduction in mortality. The side effect of this aldosterone receptor antagonist, we all know, is hyperkalemia. We should stop potassium supplements before starting the aldosterone receptor antagonist, and the potassium level and RFT should be monitored in these patients with within 3 days once, and also after 1 week. And the patient who is on long-term mineralocorticoid receptor antagonist and stable RFT and potassium level, we should do it every 6 months. Now, specific complications are there with spironolactone, which causes painful gynecomastia and impotence in males, and menstrual irregularities in females, as spironolactone has a structure similar to progesterone, but this effect is not there with eplerenone. So coming to the doses, we should start with a low dose of this AC inhibitor. Enalapril, lisinopril, and ramipril are usually used in our setup. So we start enalapril with 2.5 milligram twice daily dose, and we increase every 3 to 5 days. And maximum dose what we want to achieve is 10 milligram twice daily. Now, ramipril we start with a 2.5 milligram once daily, or lower dose 1.25 once daily, and we increase to 10 milligram once daily. Coming to losartan, we use as 25 milligram once daily and increase to 50 milligram once daily. Coming to valsartan, we start with 40 milligram twice daily, and the maximum effective dose which was seen in these trials are 160 milligram twice daily. And spironolactone, 12.5 milligram once daily to 25 milligram once daily is the starting dose, and we increase slowly to 50 milligram once daily is the maximum dose what we want to achieve. And in case of eplerenone, 25 milligram OD is the starting dose, and we increase to 50 milligram OD dose in patients with heart failure. Coming to role of RAS inhibition in patients with heart failure with preserved ejection fraction who has got LVEF of more than 45%. CHARM trial has shown that candesartan, when it was used in a patient with symptomatic heart failure with ejection fraction of more than 40%, as compared to placebo, there was fewer patients in the candesartan group who had CV death or hospitalization, but there was no decrease in total mortality, and the difference was also non-significant. Perindopril was started in patients with LVEF of more than 45% symptomatic and age of more than 70 years. There was reduction in heart failure related admissions, but non-significant p-value again. Irbesartan was used in patients with LVEF of more than 45% and NYHA class 2, class 4 symptoms, and there was no effect. Coming to spironolactone in this patient,
Voice is gone, I think.
Hello, Mainak?
Voice is not audible.
Gaurav has messaged, we'll do Arni at a different time.
What do you guys say? Because I feel Arni will have a lot of crosstalk also. So
Tomorrow, Arnie tomorrow. RD we can do tomorrow, I feel.
Okay. He can skip this part because anyways I was planning to cover this tomorrow. Hello? Mainak? गौरव फोन लगा देना उस पे एक बार.
करता हूँ.
We can call off. No, one thing what I have observed, I have observed is, it is in chronic coronary syndromes, it is difficult. Patients of chronic coronary syndromes or even previous ACS, it is difficult to rule out an indication of a AC inhibitor. Like even if the EF is normal or no angina, still to rule out an indication for AC inhibition is difficult.
They'll be hypertensive.
So that hypertension, if you are damn sure that with ambulatory also it is not there, or there is no microalbuminuria, then you can zero it out to discontinue. But the thing is, like with ramipril 2.5 and all, when there is no hypotension, So better to continue, and they are cheaper drugs. So better to continue.
Mainak, are you back?
He is logging in again. Wait. He will log out and log in.
We can call it off here, like Varshit is saying, and just take it again. Continue from tomorrow.
Yeah, that is also a good option. What is there for tomorrow?
He's joined. No, tomorrow I was planning to do heart failure with preserved ejection fraction. Na?
Okay.
Hello?
Mainak?
Tell me.
Mainak, nothing. We just had a discussion. See, because a lot of people are fatigued out. And
Okay.
also there is some overlap between this and what I was going to cover tomorrow. The mid-range and preserved ejection fraction. And because RNA is important, can we do it in 2 parts? Can we break now?
Definitely.
And tomorrow
Definitely.
again we will you start with your thing after you're done, or you you can see what I want to tell and then also say what you want.
Definitely. Anything to be added before in the earlier what topic I told?
Yeah. Mainak, you're not talking about counter regulatory RAS?
No, I have not prepared that. Okay.
Okay. No, counter regulatory RAS is important now because no, it's nothing. It's just a term given for basically what I mean over at least past from 2007 onwards actually, since they have described it. That's very important in terms of COVID-19 now. Counter regulatory RAS. If I mean, shall we discuss it now or tomorrow? Tomorrow we'll discuss, right?
Okay, tomorrow I'll discuss.
Okay, if you're not if you're not prepared for it, I'll send you an article for that. Actually, there is one good review article on that. So you'll understand why it is important. Okay, with COVID, because it's very important with respect to COVID. Why initially they thought that ACE inhibitors should not be given, and then now they are recommending to give actually ACE inhibitors as a preferential choice of antihypertensive. So
in these patients?
No, in COVID patient, like generally there was they were saying that actually it should not be given.
The receptor is same like that.
So initially it was thought that it was not to be given, but now they are preferring to give as a preferential antihypertensive in COVID patients. You go through that, you will understand. One picture you can put and you can explain from that actually.
Definitely.
Any
other
thing? No. You covered heart failure also. I was thinking you'll cover only ACS. I think so. That is why we can have a good discussion tomorrow also. Okay. Okay. Bye.
Okay, everyone. Good night.
Thanks, Gaurav. Bye.
Bye. Your topic was only half done, huh?
How to go out?